one of my colleagues. It's a pleasure for me to introduce Jill Dixon, who is a colleague of mine and a consultant in infectious diseases and internal medicine. And she's going to talk about quite a challenging case that we've recently had, and be interested in all your comments. Jill, the floor is yours.
Thank you very much. So thank you for having me this morning to present this patient. As Dr. Schmid alluded to it, this gentleman was a mystery to us in Newcastle for a couple of weeks. And we've discussed him at length within our department with my colleagues, and we found his case very interesting, and I hope you do too. Throughout the case, I'm going to stop occasionally just to pause for people's reflection to see if anybody has any questions or comments. But if at any point you'd like to stop me, please feel free to do so as we go through. Okay, so this gentleman presented to us just recently on the 8th of March. He was a 36-year-old gentleman who presented with a 5-day history of headaches, light sensitivity, nausea, vomiting, and fever. On direct questioning, he mentioned some dysuria, but no frequency or urgency, and this was only elicited on review of systems. He was usually fit and well. He had a past medical history of type 2 diabetes, but was diet controlled and taking no medication for this. He had a past medical history of depression and a pilonidal sinus, which he'd had operated previously. He lived with his parents, his brother and sister-in-law. He worked part-time in a family takeaway. He was a smoker, but drank no alcohol and took no recreational drugs. He was born and brought up in the UK. His family originated from Pakistan, but he'd had no recent travel, having travelled only once as a child. He was heterosexual with no recent partners, and on detailed history, his parents were second cousins. On examination, on admission, he was scoring as minimal risk on our early warning score trigger. So he was afebrile and his observations were all stable, but a documented temperature of 38.4 degrees had been recorded in A&E. His chest examination was unremarkable. His cardiovascular examination revealed that his capillary refill was prolonged at 3 seconds, but heart sounds were normal. Abdominal examination revealed very mild suprapubic tenderness, but no peritonism with normal bowel sounds and no distended bladder. Neurological examination revealed that he was photophobic. He was Koenig's positive and he appeared dizzy on standing. And there had been a history of rash, but on top to toe survey, the rash appeared to be intertrigo within his skin folds. So at this point, would anybody like to comment about differential diagnoses, what investigations they would like, or any questions? And if anybody doesn't wish to comment at this point, I can continue.
Antonio.
Hi, good morning to everyone. I have a few questions. First, did he report any animal or any natural water exposure recently in the last months, couple of months? Did he recall?
No, he has no pets at home. He lives in Newcastle, an urban area, and hasn't had any significant animal exposure. No hobbies like fishing or canoeing. No freshwater contact. No.
Oh, wow. Okay. Well, right now I don't have like any other question. That was the only thing that I was thinking that you didn't mention. But the differential diagnosis with this patient is quite vague in the point of no epidemiological clue or key point that have revealed for now, till now, obviously.
Indeed, nothing remarkable and nothing nothing to get us particularly excited at this point. Okay.
No. He referred at some point. You mentioned that he has some urinary symptoms, some dysuria at some point.
Yes, on direct questioning, he mentioned that he'd had a little bit of dysuria, but no other urinary symptoms. Yes, and on urine dip, it was completely normal. I think we felt that subsequently that was likely dehydration.
At some moment, did he or did he recall like any blister lesions in his genital area? Any signs of past history of herpes or well, herpes or any sexual recently in a couple months previous or couple months previous?
So no known sexually transmitted infections. We were concerned about the rash because they mentioned a groin rash when he'd been clocked in the same day emergency care unit. But when we reviewed him, it was more in keeping with intertrigo. He didn't have any vesicular rash.
Okay, I have no. For now, I don't have any more questions.
Thank you.
I have a question, if you don't mind.
Of course.
So, for how long was the patient symptomatic?
Just 5 days.
Okay. Was he getting worse and during these 5 days, or everything was stable?
No, I think it was progressive. So he presented because the headache was now particularly significant and he was very photophobic. So I think it had progressed gradually over the 5 days.
Okay. Did he have any mental status changes at some point? Confusion?
No, not at this point.
And this is the first time that he's reported these symptoms, right? Didn't have
Yes.
this before. Okay. Thank you.
Okay.
You may wish to continue.
Pardon?
Just continue.
Oh, thank you. So moving on to his investigations, his routine blood showed a slightly elevated white cell count with a neutrophil count of 7. His CRP was entirely unremarkable at 3. His glucose was elevated at 14 with a normal lactate and a sodium that was ever so slightly low at 134. He had a plain chest x-ray, which was unremarkable, and he had a CT head, which again showed nothing unusual. Because he was meningitic, he went on to have a lumbar puncture, which had an opening pressure of 33 centimeters. His protein was elevated at 1.06. He had a glucose in the CSF of 6.2 with a paired serum glucose of 14.3 and significantly elevated white cells of 597. 100% of those were reported to be lymphocytic. There was nothing on gram stain, and as you can see, it had been a traumatic tap with 397 red cells present. At a presentation, he was started on ceftriaxone, and he received this for 24 hours, and he also received a dose of dexamethasone at presentation. So his investigations so far have shown meningitis with a lymphocytic CSF, and I wondered if anybody wished to comment further at this point.
Hi, doctor. This is Jorge Alave. I have, please, could you say what is from the patient specifically?
What's wrong with the patient? Headaches, photophobia, and meningism. He was Koenig's positive, and he had a fever of 38.5
Okay.
when he was admitted.
No, is the
Where is he from?
Where's he from?
Where is she from?
He was born and raised in the UK in Newcastle in the northeast of England. His family are originally from Pakistan, but he hasn't travelled there since being a child.
Okay, yeah, excellent. So there's apparently this patient have a acute acute neurological involvement, no, to apparently infectious diseases, no. So, but the lymphocytic powder in the CSF is suggestive to meningeal viral meningitis, no? So in this context, we have several options, no? Enterovirus, no? Specifically, for example, Entero D62 or herpes virus is more common, no? Simplex herpes or I don't know, zoster herpes virus too. But another interesting diagnosis that in context is not common is TB. No, tuberculosis in Peru is relatively common, but obviously the patient, all patients referred a neurological involvement for more than 2 weeks, 3 weeks, no, chronic headache, no. So in this context, usually we suspect of TB. Another option is a cryptococcosis or in endemic fungal infection. But in non-infectious diseases, we always consider paraneoplastic manifestation of lymphoma, for example, or another immunological diseases. I don't know, vasculitis or lupus. No? So because it's very important when we approach patient with a lymphocytic powder in CSF, we consider always some infectious diseases and non-infectious diseases. Okay.
Absolutely.
Thank you.
Thank you very much.
Michael?
Thank you. Just in terms of universal good practices, I'm wondering if he had ever had a history of HIV testing, and if not, if a serology would be obtained in this at this point.
Thank you. He hadn't, as far as we could recall, had a HIV test, but we did perform an HIV test, which was negative.
Thank you.
I have a question. I know Newcastle is a city near, I think it's near the ocean. Did he recall any recently any raw seafood or any yes, any raw seafood recently in the weeks prior his presentation?
Not that we had elicited. I'm not sure if that question was asked directly, but not that we had elicited, no.
Any flu-like symptoms, any gastrointestinal symptoms, specifically diarrhea in the previous of the presentation of this patient?
No, he reported being entirely well until 5 days prior to admission, and he hadn't had GI symptoms during that point.
Well, I'm totally in line with Dr. Jorge Alave. Right now, the only differential with the lumbar puncture and the result of the cerebrospinal fluid, right now we are thinking about a CNS viral infection. Obviously, probably because of the epidemiology of the patient, maybe tuberculosis. Central nervous system tuberculosis can be a little bit lower in a differential diagnostic, but right now, what I'm thinking, and probably most of that we are hearing are thinking about a viral disease of the central nervous system right now.
Thank you.
Yes, good morning. One question: in what season of the year happened this? And two, has the patient have any contacts with children, especially small children, with extended family or related to work? Thank you.
So he presented in March, which is early spring for us, and he lives at home with adult siblings. Siblings that don't live with him do have young children, none of whom had been unwell, and he worked occasionally in a takeaway, but not in a particularly. He wasn't interacting with the general public in a significant way with that.
And his sexual history, in addition, he had all his childhood immunizations.
As far as we are aware, he has had his childhood vaccinations. His parents reported that he'd had everything offered, and he was born in the UK. He is divorced. He's been married 3 times and has had no recent sexual contacts. He tells us he's had exclusively female partners previously.
So
And
I
it doesn't.
agree. All right.
Sorry.
Yeah, I agree that most of these enteroviruses, they are the commonest causes of viral meningitis in the acute setting. But upper group of viruses could also be important: HSV, VCV. But more importantly, I don't know for that area of the country, do you have any tick issues? Maybe the patient goes to the woods, go hiking, because in that setting, then all the tick-borne infection will also present in a similar fashion.
Yes, absolutely. We do see Lyme disease not uncommonly. This gentleman hadn't had any exposure to rural areas. He hadn't been hiking, hadn't had long grass exposure or been near animals, but and didn't have evidence of eschar. But yes, that was something that we considered. And Lyme disease is what we see predominantly in the UK. With some travel, we have seen tick-borne encephalitis, but that's been in travel within Europe that we've seen that here. Yes.
It also doesn't sound like March in Newcastle would be mosquito season for thinking about things like West Nile.
No, it's cold. Yes, it's cold.
And we haven't had locally any West Nile ever yet. So
Do you guys do things like meningo encephalitis panel as part of meningitis workup?
We do. I'll show you our panels on our next slide as to how we work this up. Okay, so if there aren't further questions, so this was his initial
Dr. Soler would like to say something. I see that hand raised.
Yeah, thank you, Dr. Gonzalez. Well, I was wondering about bird exposures. Also, you asked later about woods or forest, thinking about ticks. But I will think also about cryptococcal infection and in apparently immunocompetent patient like Gatti, because it may be spread on the environment. And on the other hand, I wanted to ask if there is any exposure to foods like dry food or something that might be colonized by fungal agents that are not used to be acquired on UK, but may be acquired through imported and contaminated foods. And on the other hand, this is acute presentation yet. However, maybe we will hear from you a subacute course of disease. That's why what I was thinking about cryptococcal or other fungal infection. And also I was sorry, I also was wondering about exposure to contaminated waters or risk for leptospirosis.
Yes. So no bird contact. He doesn't keep birds or has visited any aviaries. He hasn't had freshwater contact, no river contact, no sports or hobbies that put him at high risk. No hiking, forests, long fields, long grass exposure. And in terms of food, I'm not sure if a detailed dietary history was taken, more than he hasn't left the UK, no travel, and eats largely. The family have a family takeaway, so he eats home prepared foods. Yes, but that's the extent of his dietary history that we're aware of. Nothing of risk that we know.
Thank you.
Pleasure.
Can I just mention a couple of the pathogens as a differential diagnosis?
Please.
Whenever we see a lymphocytic pattern in the CSF with a low glucose, lymphocytic pattern is usually viral infections. I mean, that's one of the parameters that we look at. But usually the glucose is normal in these patients and the protein is high. In your patient, the glucose was low. In theory, when that happens, we have to think about other pathogens. And when it's acute, we have to keep in mind Listeria. This is one of the bacterial pathogens that can actually cause a lymphocytic pattern in the CSF, and it's an acute presentation. So, not all the Listeria meningitis will cause lymphocytic pattern. I would say maybe 20 to 40% of all the patients that present with this pathogen can look like this in the CSF. But other viral infections that can usually decrease the glucose in the CSF are, for example, CMV, mumps, and Eastern equine. In theory, those have to be raised in the setting of a low glucose with the lymphocytic pattern. And the other viral infection that we have to think about will be lymphocytic choriomeningitis. And as Dr. Alavi mentioned, other autoimmune disorders, for example, in this context, NMBN, NDMA meningitis, that has to be the differential as well. Thank you so much.
Thank you. Okay, so just to talk you through our investigations, he'd had 3 sets of blood cultures sent from the assessment suite, which showed no growth. His CSF, there was no growth on that and no organisms seen. Our initial panel of testing includes HSV 1 and 2, VZV, and Entro. That was all not detected. After discussion with the lab, HHV6 was PCR was run, which was not detected. He had a cryptococcal antigen peripherally and on CSF, which was negative. He had a meningococcus PCR, which was not detected. He had bloodborne virus testing for HIV, hepatitis B, hepatitis C, and syphilis, all not detected. He had CMV serology, which suggested no acute infection. He had EBV serology, which suggested no acute infection, but that he hadn't been exposed previously. And he had CMV, EBV, and adeno PCR in his blood, which was not detected. He had chlamydia and gonococcal PCR on urine, which was also not detected. And there had been some vague history of a possible TB contact as a child. So he had a quantiferon gold TB test, which was also negative. He had MTB PCR run on his CSF, which was not detected. So despite a normal CRP and an ESR of only 18, he had ongoing fevers of above 39 degrees for over a week. Because of this, he went on to have imaging, further imaging. He had a CT venogram and an MRI of his head, which was completely unremarkable. And he had a CT chest abdo-pelvis, which looking for any occult malignancies with paraneoplastic conditions in our differential and looking for any other source of sepsis, which was his CT was normal. He had a repeat lumbar puncture on the 12th of March, which had an opening pressure of greater than 41 centimeters. His protein had come down a little bit, but was still elevated at 0.7. His glucose ratio remained about the same, around 50%. His white cell count was elevated at 695, and this was a less traumatic tap with red cells of only 24. Again, 100% of the white cells were lymphocytes, and there were no organisms seen. A similar panel was run with our standard panel of HSV 1 and 2, VZV, and Entro. We also ran CMV and EBV and adeno on the CSF. We did a toxo PCR, a cryptococcal antigen, and they did PCR for Mycobacterium tuberculosis and non-tuberculous Mycobacterium, which were both not detected. As someone mentioned, in terms of differentials, we performed Lyme serology, it was negative, mumps serology, which was negative. He had an autoimmune screen, anchors and immunoglobulins, which were all normal. He had an extended viral throat swab, which includes things like mycoplasma. It was negative. Entro on his stool, as well as CSF, which was not detected. He had hepatitis E serology, which was not detected, HTLV, and he had cytology, which showed a severe lymphocytosis but no malignant cells seen, but unfortunately flow cytometry wasn't processed as requested. He had some tumour markers checked, which were all within normal limits. He had a serum ACE checked, which was normal, and he had a CK checked, which was normal. Due to the significantly increased opening pressure of his second lumbar puncture, he had an MRI spine to make sure that there wasn't any obstructing lesion, and his whole spine and sacrum MR was also completely unremarkable. So on the 18th of March, his fevers settled for the first time. His headaches improved, but he was complaining of some neuropathic pain. He had hyperesthesia over his L2 distribution, and he was started on pregabalin due to this. He had an EEG for completion, which showed predominantly slower rhythms with no seizure activity, and the EEG raised the possibility of some degree of cerebral impairment, or may simply reflect a very drowsy state. That's the report as issued. His HbA1c was elevated at 96, and as you may remember from admission, he was diet controlled, so he was started on metformin, and his sugars controlled very rapidly on the ward. So on the 21st of March, he's feeling much better. He had remained completely afebrile and his headaches had settled. He was feeling well and he was very keen to go home. He reported that he was feeling a little bit groggy in the morning, but that cleared through the morning and he felt well during the day. And the consultant who was reviewing him thought that could be secondary to the pregabalin that had been added for his hyperesthesia. So this was discontinued. So he was discharged at this point with a diagnosis of idiopathic lymphocytic meningitis, with a plan for early follow-up in 4 weeks in the infectious diseases clinic. Unfortunately, less than 24 hours later, he was readmitted. At this point, there were concerns from his family that they reported that he'd had a fever at home overnight, that he was off balance, that he was struggling to mobilize, that he was complaining of pain in his lower back and over his left pectoral region, and that he appeared intermittently drowsy and confused. On examination, he was afebrile, his obs were stable, and of note, he didn't have a temperature at all on readmission at any point. He was mobilizing slowly, but appeared to have a steady gait. Respiratory, cardiovascular, and abdominal examination was completely unremarkable, and on a neurological examination, he no longer appeared meningitic or photophobic. He reported hyperesthesia over his left pectoral region and persistently in the right L2 region, and appeared to have quite slow responses, reduced attention, and reduced fluency. And now, if anybody has any further comments, please.
At this point, you haven't seen any new skin lesions, right?
Pardon?
At this point, have you seen any new skin lesions?
No skin lesions, and the intertrigo is actually settling well with topical creams.
I didn't hear the ME panel. Was that negative?
I'm very sorry, I didn't catch that.
The meningo encephalitis panel, was that negative in the CSF?
The meningo PCR, yes, it was negative.
It's negative. Okay.
He was on steroids when he was first admitted. How were they tapered over the course of that initial admission? And did he go home off steroids?
Yes, he did. He only received one dose of steroids. It was started empirically as cover for meningitis, but when he had the lymphocytic panel and his CSF culture was negative, that was stopped very rapidly. So he only received one dose of steroids as an inpatient.
Did they get any vasculitic workup?
In terms of vasculitis, he had MRA scanning, which didn't suggest any cerebral vasculitis. He had an ESR of only 18, and his anchors were checked, which were negative.
And was that an angio MRI or was a brain MRI for encephalitis?
Both. He had both.
Okay.
What was his occupation before this presentation?
He was working in a takeaway, which belonged to his parents.
Okay. I didn't see syphilis serology.
Yes, it was checked and was negative.
Okay.
Sahara Africa.
A quick question.
Okay.
When you actually mentioned about the pain, the neuropathic pain that he developed, was it in a dermatomal distribution? Is that what you meant when you put L2?
Yes, it appeared to be dermatomal. So it appeared it was over L2 on the right side, and it was over his left pectoral region. There was no accompanying rash, and it was unusual. He'd had a contrast enhanced MRI of his whole spine with nothing to explain that. We didn't get to the point of doing nerve conduction studies, but yes, it did appear dermatomal.
And did you repeat HSV and VZV in the second LP?
Yes, negative.
Okay, thanks.
Thank you. Okay. If there aren't further questions, I'll continue with the investigations that we did on his second admission. So, because of his
Anybody
presence,
will say what they think.
sorry.
Hi.
Sorry.
Hi. Sorry, I have a question. Did you rule out the autoimmune meningitis with the antibodies in the CSF, or that wasn't done?
They've been sent, but they're still awaited at this point.
Okay, thank you.
Thanks. Okay, so as he was now presenting as encephalopathy and had a blunted affect with some slowing of response, we repeated his MRI. Again, his contrast MRI was completely unremarkable. We repeated an EEG, and the report read background appearances would be consistent with cerebral impairment. Occasional focal features were seen over the left anterior region. These were not obviously epileptiform, appearances not classical for encephalitis. We repeated his lumbar puncture. This is now the 24th of March. And his opening pressure was 24 centimeters, so significantly improved. His protein had increased to 1.77. His glucose was 3.3. I don't have an accurate paired glucose, but that, in keeping with his BMs, would be about 50% ongoing. His white cell count was 184 with a red cell count of only 1. 100% of the white cells, again, lymphocytes, and again, no organisms seen. Are there any? We've covered a lot of differential diagnoses, and you suggested, I think, all of the things that we were thinking of. Is there anything in addition at this point?
I have a quick question. Any family history of tuberculosis? I mean, the patient was born in Pakistan, you said, right?
Yes. So initially there was some comment that he may have had contact with somebody who had TB as a child, but that was subsequently, it didn't bear out in subsequent questioning. He did have a quantiferon test, which was negative, and nothing within lung fields to suggest any granulomas or anything calcified. But yet that was questioned.
Do you guys send, I mean, in this situation, I guess, part of the workup, did you send expert in the CSF, expert for
We
tuberculosis?
did, yes, it was negative. It was sent on the first 2 lumbar punctures, both times negative.
And adenosine deaminase as well?
We didn't send that, no. We looked for Acinetobacter bacilli and we did the MTB PCRs and the non-tuberculous MTB PCRs, but we didn't send ADA.
Okay. Thanks.
Thank you.
I will be concerned about crown disease at this point with the encephalitic picture and the extensive negative infectious workup. Just to include that, maybe in the CSF or even in the blood, mainly the CSF.
Thank you.
Hi, this is Jorge. So if you have parenchymal lesions or brain parenchymal lesion, it's possible in the as you know, CSF no involvement. So in this context, obviously we consider, as Dr. Gonzalez talked, tuberculosis or not tuberculosis. But another interesting diagnosis is, for example, brucellosis. No, in Peru is relatively common. Meningitis due brucellosis, but not as frequent the local lesions or mass or parenchymal lesion due brucella, no? Or another option is in the degeneration phase of neurocystic sarcosis is another option too, no? Produce a parenchymal lesion too, but syphilis is another option too, no? Okay.
Yes, no parenchymal lesions for this gentleman. Thank you. MRI has been normal on repeat. Okay. Are there any questions before my next slide will give the diagnosis away?
Do you have malaria test?
I think that he's had one and it was negative. No travel for a long time. Yes, and no recent travel to malarial areas. But I think he's had blood films which didn't see parasites.
And your CSF is always lymphocytic, right? No eosinophils.
No eosinophils. No.
I don't know if I missed it, but did he have any pets, cats, or any other pets?
No
maybe
pets.
anything? No.
I'm sorry, I missed the last part of that question.
No, I was just worried about bacillary angiomatous that could cause some CNS involvement, but I don't know if that was checked for Bartonella and Sella.
No, so no significant travel. Born and raised in Newcastle in northeast of England, and no animal contact. As your answer to your first question.
Yes, thank you.
Thank you. Okay. So finally, we got the diagnosis. The samples had been sent on his first admission as just part of our screen, but I think everybody, including the neurologists, were a little bit surprised by the results. So finally, we found that his NMDA antibodies in his serum and CSF were both positive. And this gentleman has now been transferred over to the care of the neurologists for his ongoing care. Initially, the neurologist had very much not been, hadn't felt that this fitted with any autoimmune condition or predominantly neurological condition. They felt that it was more likely to be an infection. But we wanted just to have a little look at this case together. So we've presented this at our teaching meeting locally, just to have a look as to if this presentation was in keeping with NMDA encephalitis, as I know many of you mentioned it in your differential list. It is fairly common. So I'll go on and discuss that further at this point. So Anti-NMDA receptor encephalitis was first identified in 2007, so a relatively recent condition. As we know, it's an autoimmune disorder that causes disruption of normal brain signaling, brain swelling, or encephalitis. The IgG antibodies are directed against the NR1 or NR2 subunit of NMDA receptors in the CNS and result in reduction of neuronal calcium influx with decreased receptor-dependent synaptic currents. It's much more commonly affecting young adults and children, and women are significantly more likely to get this, with a ratio of 4:1. Trying to find accurate estimates of the incidence of this condition is quite difficult, as it is relatively new and it's entirely dependent on people testing for it. With it being a new diagnosis, it is likely that it does continue to be underdiagnosed, but approximately 1 in 1.5 million people per year can be affected. As we know, there's a very strong association with ovarian teratomas in women, to the point that actually in young women, if their initial scan for teratoma is negative when they're diagnosed with this condition, it's now recommended that they go on to have 6 monthly scans for a minimum of 4 years, because subsequent diagnosis has not been uncommon. In some case studies, in some case reviews, it suggested that there were 38% of cases were associated with paraneoplastic condition. 94% of those were ovarian teratomas, so you can see just how strong that link is. But there was a very wide list of other malignancies that could be associated with the condition. You'll see that there's solid organ tumours as well as hematological malignancies, and some skin conditions. There's also a clear association with viral encephalitis, especially herpes simplex virus, which can be associated with NMDA antibody production within 3 weeks. And certainly within our unit, we have seen NMDA encephalitis as a complication of HSV infection. The signs and symptoms of this are fairly wide-ranging. Though they have in textbooks, there are a sort of classical presentation, which is documented as having 5 phases: a prodrome, a psychotic phase, an unresponsive phase, a hyperkinetic phase, and recovery. Within the behavioral part of that, there is paranoia, hallucinations, and aggression, which actually all fit with our patient on the ward, who went on to display these things subsequently during his admission. Subtly, cognition can be affected. The patient can present with memory deficit, speech disorders, and then the unresponsive episode, patients can have loss of consciousness, movement disorders, seizures, and autonomic dysfunction. The prodrome can mimic common viral infections, and the neuropsychiatric symptoms tend to develop within weeks to months, often in a less than 3-month period. And in one series of 100 patients, 86% of the patients had a prodrome that included headache, fever, or viral-like illness, which was particularly interesting to us as a department, as I don't think that it's very clearly documented that you can present with such a profound meningitis-like illness. The neuropsychiatric symptoms can develop quite rapidly and can progress from acute subacute behavioral presentation fairly rapidly. Movement disorders and seizures are more common in children, and there can be, in terms of the psychotic symptoms, that can be very wide-ranging, from apathy, anxiety, bizarre behavior, hypersexuality, aphasia, amnesia, sleep-wake cycle disturbance, severe insomnia, and delusions. In the unresponsive phase, this can be anything from mutism, aphasia, all the way through to catatonia with decreased movement. And certainly our patient displayed quite a lot of the behavioural and cognitive presentations here. In terms of investigations, case reviews suggested that CSF abnormalities can be found in up to 80% of cases and are typically a mild lymphocytic pleocytosis with increased protein, and occasionally CSF oligoclonal bands can be seen. I think slightly out of keeping in our presentation is the extremely raised opening pressure, which wasn't in any of the literature that I could find. The MRI being normal appears to be in keeping with the condition, as well as MRIs are normal in 70% of cases. When they're not normal, you can see some hyperintensities in a variety of regions, and it would be difficult to say what a classical finding would be. In EEGs, 90% of patients affected by NMDA encephalitis have non-specific slowing at some point in the illness. So a reflection within our department was the report saying nothing in keeping with encephalitis when it was reported as global slowing may be misleading, and perhaps it would be better wording to say nothing in keeping with HSV or viral encephalitis may be more helpful. And in terms of diagnostics, obviously the gold standard is CSF or serum for NMDA antibodies. In terms of treatment, first-line treatment would always involve tumour removal if present, and that is one of the something that reflects the best prognosis if there's a tumour which can be effectively removed. Otherwise, first-line treatments would include steroids, IVIG, or plasma exchange. I found a couple of case reports that suggested that plasma exchange prior to IVIG rather than IVIG alone may improve outcome, but the numbers in these studies are extremely low. And unfortunately, it appears that only about 50% of patients would be expected to respond to first-line treatment. Response is defined as clinical improvement within 4 weeks of starting treatment. Second-line treatment, if no response after 4 weeks, includes MMF, so mycophenolate, rituximab, cyclophosphamide, or azathioprine. And refractory disease, there are a list of various different things, including intrathecal methotrexate, tocilizumab, as treatment options, but these are case reports only, and there really isn't a body of evidence there in regard to that. Looking at recovery, it appears to be fairly slow and typically occurs in reverse of symptom onset. Severe symptoms resolve first, while cognitive, behavioural and memory issues take longer to resolve. The literature I read suggested most patients make a full recovery in 2 years, but then went on to detail that 20% develop focal deficits or die, and 10% may relapse within 2 years. So actually prognosis doesn't appear to be as good as initially thought. Long-term deficits with attention, memory and executive functions are more common, and I worry for our patient as his issues were cognitive, behavioural and memory issues whilst on the ward, that his outcome may not be so good. Predictors of good outcome are the presence of a tumour that can be removed, early diagnosis and aggressive treatment. And predictors of a worse outcome are the requirement for an intensive care stay, a treatment delay of greater than 4 weeks, no improvement after 4 weeks of initial treatment, an abnormal MRI, or a peripheral white cell count of greater than 20. And it's just a couple of references for literature that we've reviewed in the write-up of this case. But I will stop sharing and would welcome any further questions. Thank you.
Just a quick question. So you guys think that this is a primary idiopathic NMDA, or you did some kind of like workup for occult malignancy, or I don't know, maybe associated with HSV because he has some neuropathic pain? It looked like a dermatomal distribution. What is the theory behind that you guys have?
He has had extensive testing for occult malignancy, so he's had multiple scans, tumor markers. His CSF has gone for flow cytometry and cytology, all of which are negative. There isn't, we haven't found as yet any underlying malignant cause. HSV PCR was not detected on any of the 3 lumbar punctures that he had. He had peripheral swabs of his groin rash, which was negative, but actually appeared to be clinically in keeping with intertrigo and responded to topical antifungal treatment, and he did have poorly controlled diabetes. So our working diagnosis for this gentleman is that it is a primary NMDA encephalitis, and that he was presenting with the prodrome, which on review of literature does appear to be fairly classical. The thing out of keeping with that is his opening pressure, but we haven't found anything despite MRing his whole spine to explain that.
Thanks.
It's a kind of interesting case. I think initial presentation was pretty much meningitic, and then the encephalitis portion now showed up later. So I think the lesson is to just think about NMDA, for aseptic meningitis that initial negative. I think that's the lesson here.
I would agree that that's definitely the thing that threw us, was that his initial presentation was of a pure meningitic illness and he wasn't encephalitic initially. It's hard because, yes, I think the likelihood is that most people who present with a purely meningitic illness are not going to have an NMDA encephalitis, but with retrospect, that probably was his prodromal part of the illness. And clearly it does go underdiagnosed. One of the neurologists came to talk to us, and he feels that quite a lot of patients in subsequently in psychiatric units have had missed NMDA encephalitis.
Can you ask if you have an explanation for the neuropathic pain? Do you think this is related or part of the NMDA, or I don't know, this is just a coincidence that he happened to have a neuropathic pain, which will be a little bit strange to me to have a dermatomal distribution? I mean, I'm not questioning the diagnosis of NMDA, but what I'm trying to say is that maybe, the CSF, the PCR meningitis panel, it has a good sensitivity, but you can still miss some cases of HSV meningitis. And when you repeat it, if it is already like 5 days apart, the HSV can become negative. So that would have been the trigger, the initial trigger for the patient to develop NMDA meningitis at some point. I'm just throwing these theories to see if you consider any of those.
And his pain was fleeting and mobile. It was unusual. So it did appear neuropathic, which is why my colleague started the pregabalin. But it did appear to move. It wasn't, and then it wasn't fixed. So it was a little bit atypical, the presentation, and certainly the pectoral region was when I was looking after him on the ward. And one day I examined him, and it was very hyperesthetic, terrible pain, and he described it as burning. The next day I came to see him, and he said that there was no discomfort. So it was very fleeting. I think it probably is part of the NMDA encephalitis panel. He did have HSV checked on lumbar puncture, which was about day 6 of his illness, and he had a repeat, a further 2 lumbar punctures with repeats, and it was negative on all 3. But I take your point that it's valid that it's not, it doesn't have a sensitivity of 100%. Absolutely.
Thanks, Jill.
Thank you.
With this NMDA receptor antibody positivity, did we go back to either review the CT tab or ask the radiologist to repeat the CT tab, possibly looking specifically at the thymus and other stuff in the chest that could.
Yeah, the CT chest abdo pelvis was reviewed in our radiology MDT. So yes, it has been reviewed looking for occult malignancy.
Thank you.
Thank you. Thank you very much, everybody. Thank you for all of your comments and suggestions. That was very helpful for us. Thank you.
Thank you very much, Jill, for the excellent presentation. Thank you for your time, and thank you, everybody. I think I said that we can end the session. And thank you for your participation, and see you next month for another case.
Thank you.
Bye-bye.
Have a nice day.